Welcome to the deep dive. Today, we're getting into something really interesting, the world of aesthetic treatments. But we're looking beyond just the procedures themselves.
Yeah, we're really digging into the decisions behind them. How do practitioners figure out what's right?
Exactly. Our source material is excerpts from a text called Decision-Making in Aesthetic Practice. It's basically written for the pros.
Right, so it gives us this, inside look at the thinking involved.
And what we want to do is kind of give you a shortcut through it all. We'll look at the consultation, which is way more than just making an appointment.
Mm.
We'll explore how they see the canvas, your skin, aging, the structures underneath.
And the treatments themselves, the toolkit they have, what things actually work for, what they don't work for.
And then how it all comes together, how a practitioner decides the best plan for you.
And just to be clear, this isn't about pushing any treatments. Not at all.
No.
It's purely about understanding the information in this source material, the approaches, the techniques, the good bits, the limitations, what this text says.
Okay, let's dive in. Starting at the beginning, right? The consultation.
Yep.
You might think it's just a quick chat, book something in.
Yeah.
But this source says no, it's fundamental. It's really the practitioner's chance to educate you properly.
Totally. They even suggest sending info before you arrive, like texts or emails explaining what happened.
So interesting. Why?
Well, it helps set expectations, gets you in the right frame of mind before you even walk through the door, sort of primes you.
Okay, that makes sense. And then when you do arrive,
Yeah.
that first moment matters.
Apparently, hugely. The greeting, eye contact, a smile, telling you clearly where to sit, what forms to fill out. It sounds basic, but...
But it makes you feel welcome, cared for.
Exactly. And the source suggests that builds trust, makes you more comfortable for the really important chat that follows.
Right, the actual consultation.
Which has a structure.
Yeah, it starts with assessment. That's like step one, absolutely crucial. They need your health background, obviously.
But more than that, yeah, your motivations. Why are you here? What are you hoping to achieve? Your aspirations.
And this is where it can get tricky, right? The source talks about misalignment.
Precisely. Sometimes what you want, well, it might not match what's medically needed or even possible.
Like the example they give, someone comes in, thin skin, maybe older skin, and they want a thread lift straight away.
Right. But the practitioner, understanding the skin quality, might think, hold on, we need to improve the skin first. Otherwise, the threads might not hold well, or it might not look good, or even be safe.
So the practitioner's expertise has to guide things.
Absolutely. So after that assessment, once they get your goals and your skin's condition, then they can talk options.
And educate you on why those specific options are being suggested.
Exactly. Then it's about evaluating that plan together.
Checking in. Like, how does this sound? What appeals to you?
Yeah. Any more questions? It's collaborative. You decide the next steps, maybe scheduling together.
From the clinic side, they might look at things like conversion rates or how much a patient spends over a year.
They might. The idea being if you educate the patient well at the start, build that trust. They're probably more likely to stick with the plan, maybe come back for more later.
But the source also offers this contrast, this challenge.
Ah, yes. That was quite powerful.
It pits the financial side against the reward of really nailing it for the patient, seeing them genuinely happy.
Right. It asks practitioners to think, what was your best moment? Landing a big treatment package or seeing that patient who just can't stop smiling at their reflection.
It puts the focus back on the patient's well-being, doesn't it?
It really does. And speaking of the patient's perspective, psychological assessment comes up as important too.
They mention a specific tool, the Appearance Anxiety Inventory.
Yeah, AAI. It's pretty straightforward, 10 questions, gives a score out of 40 on appearance-related anxiety.
And a high score is a flag.
Over 20, the text suggests, might indicate a higher risk of, underlying clinical issues, things that maybe need addressing separately or first.
And there was another quick method, STEP.
Yeah, just a quick way to gauge motivation. Stress, target, envision, proactive. Helps check if the stressor is realistic or if maybe someone else is pushing them into it.
So it's about making sure the person is a good candidate, not just physically, but mentally too.
Exactly. Suitability on all levels.
Okay, so stepping back from the consultation, let's talk about the canvas, the skin, aging, what's underneath.
Right. The source really emphasizes how complex skin is. It's an organ.
And as it ages, we see the obvious things, wrinkles, maybe pigmentation spots, skin getting looser, losing volume.
Yeah, and that's from both our internal clock, our genes, the intrinsic stuff, and external factors. Sun damage is a big one, lifestyle too. extrinsic factors.
And it's not just the surface layer we see.
No, definitely not. Below the dermis, you've got the subcutaneous layer, the hypodermis. That's fat, connective tissue.
Does more than just keep us warm.
Oh, yeah. It's crucial for the shape, the contour of our face and body, soft tissue volume.
So aging isn't just wrinkles appearing. There are deeper changes happening.
Big time. That subcutaneous layer changes. Fat compartments shrink and shift downwards. The muscles age. Even the ligaments holding everything up weaken.
Ligaments, like anchor points.
Sort of, yeah. And even deeper still, the actual facial bones change shape over time. They can resorb, shrink back a bit.
Wow. So all of the fat, ligaments, bone changes contributes to the sagging and folds we see.
Absolutely. Understanding that whole 3D picture is fundamental for any practitioner trying to address aging effectively. You have to know what you're working with, structurally.
Okay, so with that complex canvas understood, let's get into the treatments, the toolkit.
Right. The source breaks them down into categories: topical surface, energy-based, mesotherapy, and others for specific spots.
Let's start with topical and surface. These sound like the entry point, maybe for younger people or prejuvenation.
Often, yeah, things you might use at home or have done fairly easily in a clinic, like vitamin C serums.
What's the deal with vitamin C?
Well, the source notes is pretty easy to incorporate, can give a visible brightening effect. But it also includes a little pearl of wisdom that it oxidizes really easily. Light and air are its enemies, so the packaging it comes in, really important for it to actually work.
Good tip. Then there's retinol, vitamin A, that's a big one.
Huge. Called the gold standard since, what, the 70s? It basically encourages older skin cells to act younger, stimulates cell turnover, boosts collagen production, improves blood flow.
Yeah.
It does a lot.
Benefits sound good lines, brightness, helps oily skin, fade spots.
Yep. The downside can be initial dryness, maybe some flaking while your skin gets used to it, and generally avoided in pregnancy or breastfeeding, just to be safe.
Any pearls for retinol?
Yeah, the source mentions encapsulated retinol.
Yeah.
Because it releases slowly, it tends to cause less of that initial irritation for some people.
Okay, moving into the clinic now. Skin peels, chemical peels.
Right. Apparently, they go way back. Ancient Egyptians used acidic substances.
Wow, so what do they do now?
They use chemical solutions to remove outer layers of damaged skin. Helps with texture problems, uneven color, sun damage, and it stimulates new cells and collagen underneath.
Different strength.
Yeah, superficial, medium, deep. Depends on the acid, its concentration. Glycolic acid is common for superficial. TCA is stronger. You see a frosting on the skin.
And deep peels.
Phenol is the main one mentioned. Very powerful. Needs local anesthetic, even heart monitoring sometimes. So, peels aren't always just a quick lunchtime thing.
Got it. What about dermaplaning? Sounds sharp.
It uses a sterile blade, yeah, but it's gently glided over the skin. It exfoliates, removes dead skin cells, and that fine vellus hair, peach fuzz.
And the benefit?
Brighter skin immediately, helps skincare products sink in better, triggers cell regeneration. Pretty safe for most skin types. Can help with fine lines, some acne scarring.
Downsides?
Minimal, usually. Maybe some redness right after. Not for really reactive skin, or if you have active breakouts, rosacea flares, open wounds. And sunblock after is crucial.
Always. Okay. Microdermabrasion. Sounds less sharp.
Huh? Yeah. Also has ancient roots. Apparently, Egyptians used something like sandpaper. Modern version uses a machine, a wand.
How does that work?
Either sprays fine crystals onto the skin or uses a diamond-tipped wand, and it has suction, like a tiny vacuum cleaner for your skin's surface.
What's doing?
Exfoliating. Removing dead cells, impurities, improving texture.
Okay, moving a bit deeper now. Mesotherapy treatments.
Right. The focus here, according to the source, is really on the skin quality itself. Texture, hydration, elasticity.
Things we might overlook if we're just focused on wrinkles.
Exactly. But the source points out that how your skin looks, its texture, evenness, glow, massively impacts how young or healthy you appear.
So how do they get stuff into the skin for mesotherapy?
Different ways. Nappage is lots of tiny, shallow injections, leaves little bumps that disappear. Microneedling pens use vibrating needles.
Creating tiny channels.
Yep, microchannels. Lets products get in deeper, plus the needling itself stimulates collagen. Mesotherapy guns can automate the injections, making it faster, maybe more precise with depth.
And derma rollers. Those things with needles you roll at home.
They mention those too. Creates channels, but the source notes a potential issue. Because the needles enter and exit at an angle as it rolls, it might create more of a tear than a clean vertical channel.
And that matters.
Potentially. Might lead to a different, perhaps less ideal type of collagen forming compared to vertical needling.
Interesting detail. What kind of products are delivered this way?
A few categories. Skin boosters are often hyaluronic acid-based, not thick fillers, but thin HA for hydration. Helps keep fibroblasts happy, stimulates a bit of collagen.
Does the HA last?
Non-cross-linked HA itself.
Yeah.
Not long, maybe less than a day, but they often add vitamins, minerals, nutrients for the skin cells.
Then there are biostimulators, different from boosters.
Yeah, these are designed to spread out more under the skin and stimulate your own collagen production over a larger area. Less about instant volume, more about gradual improvement and tightening.
What are they good for?
The source suggests people noticing dehydration, dullness, early laxity, maybe 40s to 60s when collagen loss really kicks in, or even younger as prevention. They tend to give more tightening than boosters.
Okay. Growth factors. Sounds high-tech.
They're proteins your body naturally makes, like messengers. They bind to cells and tell them to do things, grow, make collagen, make elastin, repair,
Because you can inject these.
or deliver them via microneedling. Helps kickstart regeneration, new blood vessels, more collagen, painless with needling, no downtime.
Limitations.
They're big molecules, so just putting them on the skin doesn't do much unless they're specially formulated or you create channels, like with microneedling, to get them in.
Makes sense. And PRP, platelet-rich plasma, that uses your own blood.
That's the one. Take a blood sample, spin it down in a centrifuge.
Separates the layers.
Yep. You get red cells at the bottom, plasma at the top, and this thin layer in between the buffy coat that's packed with platelets. You take the platelet-rich part of the plasma,
And inject that back in.
because when platelets are activated, they release a whole cocktail of growth factors. Stimulates repair, regeneration, collagen.
Useful for.
The source mentions it for under-eye circles caused by thin skin, also as an add-on to other treatments to speed up healing. Complications are mostly injection-related bruising, swelling, maybe infection if technique isn't sterile.
Okay, shifting gears now to energy-based treatments.
Yeah.
Devices using energy.
Right. Various types. Plasma ionization is mentioned as relatively new.
Plasma, like in space.
Sort of. It uses electrical energy to ionize gas between the device tip and the skin, creating a tiny plasma arc. This causes sublimation, turns tiny spots of skin tissue directly into gas.
Without burning surrounding tissue.
Supposedly less heat transfer. The effect is contraction, tightening, said to be effective for eyelids, non-surgical blepharoplasty.
Any tips on that one?
Yeah, the source notes that devices using direct current DC might offer better depth control and potentially less risk of scarring compared to alternating current AC ones. A technical point, but maybe important.
Good to know. Then the big ones. Laser and IPL.
Intense pulsed light. Both use light energy, but lasers are focused beams of a single wavelength, while IPL is broad-spectrum light filtered for certain wavelengths.
Different types for different jobs.
Loads of types. Ablative lasers remove thin layers of skin. Non-ablative heat the deeper layers without damaging the surface. Q-switched lasers are good for pigment tattoos, birthmarks. Newer low-fluence ones are better for darker skin types. And hair removal, of course.
How do they actually work?
They target specific things in the skin that absorb light, called chromophores, like melanin for pigment in hair, water for resurfacing, hemoglobin in blood vessels for vascular issues.
What's treatment like?
Varies. Might need numbing cream, protective goggles are essential, cooling might be used. Ablative lasers are more intense, might need local anesthetic or sedation, and involve significant downtime with dressings.
Who's a good candidate?
People with pigmentation, scars, lines, mild laxity, uneven tone, unwanted tattoos or hair, spider veins, lots of applications.
Downsides.
Again, depends on the type. Can trigger cold sores,
Right.
risks of temporary or sometimes permanent pigment changes, darker or lighter spots. Redness and swelling are common. Small risk of scarring, especially with deeper lasers near the eye.
Technology moves fast here, I bet.
Absolutely. The source mentions it's rapidly evolving, even looking at lasers as a way to help deliver drugs into the skin.
Okay. What about phototherapy? LED light.
Yeah. This is non-invasive. No UV, no heat, just specific wavelengths of light shown on the skin. The evidence for it is growing.
Different colors do different things.
That's the idea. Blue light, around 415 millimeter, targets acne bacteria.
Kills them off.
Helps destroy them, yeah. Red light, around 633 millimeters, is more for regeneration, boosts cell energy, collagen, elastin, circulation, gives that instant glow sometimes.
And near infrared.
Around 830 millimeter penetrates deepest. Good for wound healing, increases collagen density, anti-inflammatory, can help with pigmentation. Red and near infrared, often used together, seem to work synergistically.
What's the treatment like?
Painless, Pleasant, even relaxing. You just lie there for 20, 30 minutes. Low cost, minimal practitioner time needed per session. Can be standalone or added onto other things.
Limitation.
You usually need quite a few sessions for significant results if you're only doing LED. Like twice a week for maybe up to 10 weeks, the protocols mention.
Okay. High-intensity focused ultrasound, HIFU.
Right. Uses ultrasound energy, but focused very precisely to create heat points deep in the tissue.
Like how deep?
Can target the dermis, the subcutaneous fat layer, even the SMAS layer, that's the structural layer surgeons lift in a facelift.
And the heat does what?
Stimulates collagen production, leads to tightening and lifting over time.
Mm-hmm.
Used for mild to moderate sagging on the face, neck, body, brow lifts, under-eye tightening.
Sounds powerful. Any restrictions?
Oh, yes. Lots of contraindications. Pregnancy, breastfeeding, heart conditions, pacemakers, blood thinners, cancer history, metal implants in the area, certain diseases like diabetes, epilepsy, autoimmune conditions.
So patient selection is key.
Absolutely critical, especially if trying it instead of surgery, like for eyelids. And it often takes multiple treatments, maybe 3 or more, spaced weeks apart. Also, darker skin types might be more prone to pigmentation issues after.
And finally, radiofrequency, RF.
Uses electrical current to create heat in the tissue via an electromagnetic field. Different device types, monopolar, bipolar, multipolar, target, different depths.
Similar goal to HIFU, stimulating collagen.
Pretty much, yeah. Heating the dermis or subcutaneous tissue to around 39-42 degrees C triggers that response. Some RF devices use microneedles to deliver the energy deeper. Some combine it with other things like vacuum or light.
Any pearls here?
Modern devices have temperature sensors built in. Older ones didn't always, and there were reports of accidentally overheating and damaging fat, causing unwanted volume loss, especially in the face. So tech improvements matter.
Complications generally related to heat.
Yeah, potential for burns or thermal injury if not done correctly, too much energy, holding it in one spot too long.
Okay, that's a huge toolkit. Let's talk about applying it. How do practitioners target specific areas? Starting at the top, the forehead.
Key concerns, there are usually horizontal lines, those vertical 11s between the brows caused by frowning muscles, the Nabella complex, and maybe volume loss or shape changes.
Treatments.
Often neurotoxins like Botox for the lines caused by muscle movement. Relax the muscle, smooth the line. Fillers can be used if there's volume loss or to reshape the contour. Sometimes both are needed.
Moving down to the eyes. The periorbital region, delicate area.
Very. A big one is that hollow under the eye, the tear trough. Often from fat loss as we age, makes the lower lid look longer.
How's that treated?
Hyaluronic acid fillers are common. The source emphasizes using softer ones that don't attract too much water to avoid puffiness. PRP is also mentioned, especially for improving thin skin quality that makes dark circles look worse.
This area sounds tricky for complications.
It can be. Bruising, swelling are common, but you can get lumps, bumps, lymphatic issues, that bluish Tyndall effect if filler is too shallow. And though very rare, the most serious risk is injecting into a blood vessel, which could potentially affect vision. Needs real skill and anatomical knowledge.
The source mentioned a case study for crow's feet.
Yeah, showing how botulinum toxin injected carefully at the sides of the eyes can relax those muscles and smooth out the lines effectively. Grade 3 down to grade 0.
What about temples? Eyelid hooding? Eyebrow position?
Yep, all discussed. Temple hollows can be filled. Hooding might be from volume loss above the lid, so filler there can help. Eyebrow position is interesting. It's a balance of muscles pulling up and pulling down.
So you can lift the brow with neurotoxin.
By weakening the muscles that pull the brow down, like the corrugator frown muscles and parts of the orbicularis eye muscle, you let the main forehead muscle, frontalis, lift it more effectively. But you have to be careful not to overdose the frontalis itself, or the brow will droop.
Tricky balance. Can fillers lift the brow too?
Yes, placed strategically along the brow bone, they can provide support and a subtle lift. Again, needs careful technique in that vascular area.
Okay, the nose.
Yeah.
Important for facial harmony.
Definitely. They talk about angles, like where the forehead meets the nose bridge, smoothing out dorsal humps, refining the tip's projection or rotation.
Non-surgical nose jobs.
Using dermal fillers, yeah. Typically firmer, more structural HA fillers. Careful injection is key due to the complex blood supply.
Mid-face and cheeks.
Yeah.
All about volume loss.
Largely, yeah. Those facial fat pads shrink and slide down. Fillers, often placed deep on the bone using a cannula for safety and smoother results, can restore that volume and lift.
Around the mouth, the perioral area. Lips, lines.
Lots going on there. Lip volume and shape with fillers. Vertical smokers' lines treated with fillers, maybe neurotoxin, maybe resurfacing. Gummy smiles where too much gum shows can often be improved by relaxing the upper lip muscle with neurotoxin. Nosolabial folds, too, often needs a combination approach.
The chin, how's that assessed?
Projection is key. Does it line up well with the lips and nose in profile? Fillers can augment a weak chin. Neurotoxin can smooth chin dimpling or wrinkles.
And finally, jawline and neck. Jowls, definition.
Big area of concern for many. Fillers can help redefine the jawline. Neurotoxin can soften prominent neck bands.
And that jawline slimming thing.
Right.
Treating the masseter muscle.
Right. Overactive masseter muscles, often from grinding or clenching, can make the lower face look square or wide. Injecting neurotoxin into them reduces their bulk.
It slims the face.
Creates more of a V shape, yeah. And it can really help with the teeth grinding symptoms, too. The source shows a case of a man treated with quite high doses for severe masseter activity, with injection points marked.
Okay, shifting from the face, the source covers the scalp too. Hair health.
It does. Starts with basics. Hair is keratin, grows from follicles and cycles growth, transition, rest, shed. We lose about 100 hairs a day normally.
Hair loss happens when that cycle gets messed up.
Or when follicles shrink, like in genetic pattern baldness, androgenic alopecia. For non-surgical treatments to work, you generally need follicles that are still there, even if they're small and weak.
How do they assess hair loss?
Things like trichoscopy, using a dermatoscope on the scalp, sometimes taking hair samples. For men, the Norwood scale is commonly used to grade the pattern and severity.
What are the treatment options discussed? Starting simple.
Oral and topical meds are often the first line for early signs, if follicles are still viable. Minoxidil, Rogaine is over the counter. Can slow loss, maybe some regrowth, but you have to keep using it.
Side effects.
Scalp irritation is common. Less often, things like palpitations, maybe unwanted facial hair.
And finasteride. Propecia.
Prescription, mostly for men. It blocks an enzyme that converts testosterone to DHT, and DHT is what shrinks the follicles in male pattern loss. Reduces loss, helps regrowth, especially on the crown. Again, only works while you take it.
Side effects there.
Can include sexual side effects, like decreased libido or erectile dysfunction in a percentage of men. Use in women is more controversial, but some studies on topical forms look promising without the systemic hormone changes.
Okay, moving to minimally invasive injectables for the scalp.
PRP comes up again. Same principle. Inject concentrated platelets, release growth factors, stimulate the follicles, increase hair count, thickness, blood supply. Various protocols exist.
And growth factor therapy? GFIT.
Similar idea, but injecting specific manufactured growth factors instead of using the patient's own platelets, delivered via microneedling. Might be an option if PRP isn't suitable, like for smokers maybe. Shows promise in studies, usually involves a series of sessions.
What about camouflage or more permanent solutions?
Scalp micropigmentation, SMP. It's basically a medical tattoo.
Tiny dots.
Exactly. Tiny dots of pigment placed in the epidermis to mimic the look of hair follicles. Creates an illusion of density or a shaved buzz-cut look. Lasts several years, typically around 5.
Technique is important.
Crucial. Too deep, the dots can blur. Too shallow, they fade fast. Used to camouflage thinning areas, receding hairlines, scars from surgery or injury. The source shows a case improving a Norwood III to look like a Norwood buzz cut and camouflaging a scar.
And the surgical option, hair transplants.
Yep. Taking follicles from a donor area, usually at the back of the head, and moving them to bald areas. 2 main methods, FUT, taking a strip of scalp, and FUE, extracting individual follicles.
FUE sounds less invasive.
Leaves tiny dot stars instead of a linear scar, often more comfortable recovery. Allows harvesting from tighter scalps, too. It's surgery, so risks like scarring, infection, swelling exist, but can provide permanent results for the right person.
Okay, we've covered a huge amount of ground. How does eye practitioner pull all this together, make the actual decisions?
The source really stresses integrity and a customized approach. It's not one size fits all. Patient selection comes up again and again as vital for success.
Most people just want to look refreshed.
Pretty much. But getting there requires that deep consultation and a tailored plan. And crucially, understanding limitations.
Knowing what non-surgical can't do. When surgery might be needed.
Exactly. Some goals just aren't achievable without surgery. Being honest about that is key.
The text also revisits the complexity of aging.
Right, reminding us it's skin, muscle, ligaments, fat, and bone. Those underlying structural changes are just as important, if not more so, than the surface skin changes for overall appearance.
And they highlighted a specific challenge: The negative vector.
Yeah, in the eye area, it's when the eyeball itself sits further forward than the cheekbone below it.
And why does that matter for treatment?
Because if you just add filler to the hollow under the eye without considering that relationship, you can actually make the eye look puffier or bulge more. It emphasizes needing to assess the bone structure, the eyelid support, the fat pads, everything, before deciding how to treat that area. A really good example of deep assessment.
They also used facial trauma as an example.
Yeah, to show how combining approaches works in complex cases, trauma can speed up aging, so maybe plastic surgery is needed for structure, but then adding regenerative things, growth factors, PRP, fat grafting can boost healing and improve the final aesthetic outcome and even well-being.
There was a case study.
Yes, a young woman with premature aging after an accident, treated with a surgical facelift plus microdermabrasion, fat grafting, growth factor injections, and epidermal cell suspension, showed significant improvement by combining surgical correction with regenerative boosts.
So ultimately, the decision comes down to
The practitioner's knowledge, their skill, their awareness of all the options, surgical, non-surgical, regenerative, and matching those capabilities to your specific needs and goals, helping you align, as the source puts it, your outer appearance with your truest inner identity.
wow, okay, that really was a deep dive. We've gone from the nuances of the consultation, understanding motivation, psychology, through the complex layers of how we age.
Do this huge range of treatments. Topicals, peels, microneedling, boosters, biostimulators, growth factors, PRP.
Energy devices like plasma, laser, IPL, LED, HIFU, RF.
Targeting specific areas from forehead to jawline, even the scalp with things like SMP and transplants.
It's clear it's so much more than just picking a procedure. It's assessment, anatomy, physiology, psychology, technology.
And managing expectations realistically, understanding what's possible, what's not.
The goal seems to be harmony, addressing specific rated concerns, often combining approaches for the best outcome.
Exactly. It's about understanding those deep biological processes and making really informed choices based on all these complex factors we've discussed.
Which leads to a final thought for you, our listener. Hearing about this level of detailed assessment, the need to weigh so many factors, structure, skin, psychology, technology, in aesthetic practice.
Oh.
How might that influence how you approach making complex decisions in other parts of your life?
Situations where you need to understand underlying systems, balance different options, and work towards a specific desired outcome. Something to think about.
Thank you for joining us for this deep dive.